Thank you so much to Larry and to everybody at the Philadelphia Citizen. And thank you so much to you, Sarah Lomax Reese, and the team here at WURD for making this program happen. I'm very, very excited, honored, and humbled to introduce our speakers and our panelists. And I hope that everyone will find this program super informative and engaging. First up is Dr. R.E.A.L Stanford, who, number one, is a hero, but she's also a pediatric surgeon who founded the Black Doctors COVID-19 Consortium, a volunteer army that has tested thousands of African Americans for coronavirus for free. This week, the city of Philadelphia awarded $1.3 million in funding to the consortium. Dr. Stanford is the founder of R.E.A.L, Concierge Medicine Co, a health advocacy and consulting firm. She grew up in North Philadelphia and is the first African American woman pediatric surgeon trained entirely in the United States. Our next panelist, welcome, Dr. Stanford. It's great to see you. Thank you for being on board here. Our next panelist is Dr. Stephen Klasko. He is the president and CEO of Jefferson Health and a transformative leader and advocate for a revolution in our systems of healthcare and higher education. Well before COVID-19, Dr. Klasko had been calling attention to and combating racial disparities in healthcare.
No, I can't hear anything. I could before, yeah.
His forthcoming book, Unhealthcare, a manifesto for health assurance, to be published June 27th, 2020, offers a provocative and innovative vision for a systemic and inclusive healthcare cure. Dr. Stephen Klasko, welcome to the program. Dr. Stanford, the pandemic has exposed the depth of disparity in health, life expectancy, and the chronic diseases that we're all familiar with by now across racial lines. How can we use this moment and really the nation's focus on racial disparity in general to think about and to address this issue within healthcare and kind of like a more overall holistic sense of what wellness is for the Black community?
Thank you. Nice to see you. I really coined it into 3 words, and that's access, empathy, and action. Hi. Oh, okay.
I don't think you can hear us. Dr. Klasko, we can hear you, but I don't know if you can hear us yet. Can you hear us, Dr. Klasko? No, we're still working it out. Dr. Stanford, go ahead with your answer. You said 3. You're breaking it down into 3. Yes.
Right. That is access, empathy, and action. And when this came about, obviously the pandemic, and we were going through it in March, the kids were coming out of school, and then we started getting more details about how it was affecting our communities. Many people started to call me in the city and say, I tried to get tested. I showed up at the hospital with my script. They wouldn't test me because my doc wasn't on staff. Or I took a bus and a train to get there. I couldn't get tested because I wasn't in a car. Or I'm 50 and you had to be 65 to get tested, so I couldn't. And so that was access, right?
Wow.
And then there were some folks who were 75 and didn't have a prescription, and they still couldn't get tested. And that was just empathy. You know, a 75-year-old man comes in without a script and somehow you can't figure out how to test him. And then the third was action. So when the Tribune reported that African Americans were disproportionately affected, I reached out to the city, to state officials, Congress folks to say, hey, what are we doing in Philadelphia? I'm a surgeon. We're not operating much right now. How can I help? And I got crickets. I got, well, we have some testing locations. People can go. And I said, no, people are calling me and saying, I'm trying to get tested and I'm letting you know this. And I wrote letters and so forth, and people were responsive, but it wasn't action. And so that's when I got into, so action, empathy, and access. I'll pause and see if Dr. Klasko can hear it.
Dr. Klasko, can you hear us now?
Yeah, I can. Can you hear me?
Yes, we can. Awesome. Dr. Klasko, the first question that I posed to Dr. Stanford, I'll pose it to you. The pandemic has exposed the depth of disparity in health, life expectancy, and chronic diseases across racial lines. How can we use this moment and the nation's focus on racial disparity in general to address these issues broadly in healthcare?
Well, it's a great question, and I can't tell you how excited I am to be on WURD with you, and especially to be with Dr. Stanford. Your introduction was exactly right. She is a hero. By the way, I started my career as a DJ, and my first internship was with Georgie Woods on WDAS.
Wow!
I'd be Georgie Woods, the guy with the good side. I'd be happy to be invited to WURD.
Shout out to Georgie Woods, the late great Georgie Woods. Shout out to him.
But look, I think like a lot of things, yes, right. The pandemic and the fact that almost twice as many African Americans and people from underserved areas died and were on ventilators than you would expect based on the demographics might have made that really a headline. But the fact is, for 20 years, I've been talking about the fact that we spend 80% of our dollars on things that only matter about 20% of the time. In some respects, the pandemic has proven that Bernie Sanders was exactly right about the problem and maybe exactly wrong about the solution. What I mean by that is Senator Sanders has been talking for a long time about the fact that we have a system, a fee-for-service system, an insurance system, a provider system, and a pharma system that are all based to bring profits to those companies and ignore a good part of the population. In some respects, we have the best healthcare for 20 or 25% of the population. And Philadelphia is really the prime example of that. We go to the Rocky statue. You walk 5 minutes right of the Rocky statue or 5 minutes left of the Rocky statue, and there's a 20-year difference in life expectancy. It's not because we don't have enough hospitals. Now, I think the pandemic might have also proven that Bernie Sanders was 100% wrong about the solution, but just leave it to the government to solve, because we clearly didn't have a coordinator response. But look, health disparities and racism on public health crisis is no different than climate change. There's barriers to exercise, affordable food, good housekeeping, cheaper mortgages. And I think when we talk about systemic racism, I'm going to put this into health. We tend to look at components. And Dr. Stanford knows this from her practice, but if somebody comes in with a rash, we can treat the rash and miss the whole systemic thing. The rash could be a sign of Lyme disease or much worse. So really great doctors, like Dr. Stanford, I'm an obstetrician, so we're on both ends of that continuum. Really great doctors say, yes, I'll treat the rash, but then I got to figure out what it is. So the fact is that we have not cared in Philadelphia about the population. You look at what happened with Hahnemann. Hahnemann was owned by a for-profit called Tenet, got sold to a hedge fund guy and his wife, and everybody said, what could go wrong with that? Einstein, another state hospital in North Philadelphia, in similar trouble, and we were looking at merging with them, and everybody pounced on that. Oh, that can't happen. So we just need a total redo in how we look at care, what we call health assurance, getting care out to where people are, where all the people are.
Yeah, I'm gonna definitely come back to the health assurance piece in a few minutes, but I want to circle back to Dr. Stanford. Dr. Stanford, you had empathy right in the middle of your comments in the first response, and I wonder if you can riff on that a little bit, because I feel like empathy is a big issue for how we cross and close the disparities that exist racially. So, what does empathy look like in healthcare?
So I can just give you some examples of what I've seen. I had an older gentleman come to one of our testing sites who was a mortician, and he had been burying Black men and women who had died from COVID every single day for 2 months. And he went to a testing site in West Philadelphia after a long day and was turned away because he didn't have a prescription. So access, you put it in his neighborhood, but a barrier because he couldn't get tested without a script. Now, empathy would be one of those testers saying, sir, your profession is this, you're high risk, we have a doc here that has to clear everything, let me see if I can get a script for you. Or, do you have a primary care doc? Let me get one for you. Or just anyone, a nurse practitioner, a PA, anyone could have taken responsibility for that gentleman and for him not have to wait for the next time there was a testing site to get tested. That's empathy. And so, as Dr. Klasko was saying, yes, these hospitals closed, and yes, there are all these business things out here. But for the 5 medical schools that still exist, and we have some of the greatest healthcare in the nation, everyone should have access to it. Okay. And then once you get in, be happy that the person is there. Be empathetic to them and their needs. Know their story. Don't assume when you see a family come to the ER, you suck your teeth. Oh, they keep using the ER as their primary care doc, which I hear over and over, but you don't pause to know that mother or father left for work at 6 a.m., took 3 buses to get to a job in the suburbs, only to get home at 9 o'clock at night, check on their kids and check their homework. And the doctor doesn't have any weekend hours when they're free. So that's why they're going to the ER to get their physical forms filled out for their children. That takes empathy. That takes asking a question rather than having your own bias as to why a particular group of people use that facility at that time for their, quote, primary care. That's why empathy is in the middle. You can't just open the door, which we're still trying to get the door open. But once someone comes through the door, you need to be empathetic, know their story, get to know them, treat them like you would treat your brother, your sister, your mother, your father.
Dr. Klasko, related question, because the anecdote you gave about being able to walk a short distance in either direction from the Rocky statue and have a 20-year span of life expectancy, that is an anecdote that's true, but also designed to create empathy, right? So what else are you seeing and doing in your research to bring that piece of it, the empathy piece, into how we think about healthcare?
Yeah, well, thanks, because a good part of my research over the last 20 years has been around self-awareness and empathy, both in the educational healthcare system. Let me give you 2 examples. In 1978, and I'm old enough to remember that because that's when I was a senior in medical school, 4% of matriculating medical students were African-American males. We doubled down on everything that hadn't worked. And miraculously, in 2017, 4% of matriculating medical students were African-American males. The fact is, when you look at the problem, again, like everything that Dr. Stanford said, stop trying for easy fixes. The problem is that we still accept students based on science, GPA, MedCats, and organic chemistry grades, and somehow we're amazed that doctors aren't more empathetic, communicative, and creative. And here's the rub. If you just do it based on multiple choice tests, and you have that disparity in education that we have, then folks from historically Black colleges and universities aren't going to get in at the same rate. And what ends up happening is, I'll give you a tale of 2 cities in Philadelphia. There are people in Philadelphia whose moms and dads pay $100,000 to get little Johnny or little Mary 5 Princeton reviews, a couple tutors. That's without even photoshopping their face on a cross player to do well in the MedCat. And then there's another kid, the batter of Barron's book, that wants to go back to West Philadelphia and be a family doctor. That is not an even playing field if everything's based on MedCat. We started a medical school where we chose students based on self-awareness, empathy, communication skills, and cultural competence. 56 students a year, quadruple diversity. And the reason that makes sense today is it used to be I had to memorize a lot of stuff, but now 90% of that stuff is on my iPhone. So I think on the academic side, we need an extreme makeover of how we select and educate medical students. On the critical side, I think Dr. Stanford put it exactly right. We label people. The whole issue of, are you on Medicaid or do you have insurance? That doesn't exist in other countries. And by the way, I don't take Medicaid, or I only take so many Medicaid.
Right.
So the moment you say you are on Medicaid, I have this vision, right? So it's a little bit like what we talk about with and what we're protesting against on the police side. I view certain people differently. I have an assumption about certain people differently than I will about others. We do the same thing. Oh, we have a Medicaid patient that wants an appointment. So that's all broken. And what just frustrates the heck out of me, we spent the last 16 years in policy talking about how we can pay for a totally broken system instead of fixing the system. The fact is that Mrs. Jones from Hill or Mrs. Jones from Strawberry Mansion should both have insurance. And the only question should be whether or not the government is supporting that insurance or she's paying it herself. And that should be transparent to the doctor and hospital. Then when Mrs. Jones calls, oh, yes, of course I'll see you right away, as opposed to, oh, what kind of insurance do you have? Oh, I have Medicaid, and having the doctor say, well, we can see you in 2 weeks. That's systemic racism in a way by calling Medicaid the trigger.
That's incredible. Dr. Stanford, I'm very happy that the city put up $1.3 million for the work that you've already been doing. And I can tell you that we had callers calling WRD who were upset when your initiative, when the Black Doctors for COVID-19 was not really included in the early conversations about the budgetary process for the city. I think two questions here. One is $1.3 million enough? Number one, and number two, how can people who want to support what you're doing, how can we get out here and support the efforts that you're doing to sort of try to close some of these gaps that we're seeing with coronavirus testing?
Okay. The short answer is no, but it's a good start. And with that, it was an acknowledgement of what we're doing. We started on April 16th. I think Philadelphia really started to be aware in about March with regards to coronavirus. And in 26 sessions, we've tested 5,400 people, which is on average about 210 people per session. The city has 47 testing sites, and they've been testing obviously much longer than us. We've tested 111,500 and something people, which is on average about 28 people tested per site. Wow. So we were testing at 9 times the rate of the city of Philadelphia with volunteer people. And so I can't imagine, and I know I'm innovative, I'm creative, I'm an advocate, and some will call me pushy. However, I can't believe that with the institutions we have in this great city, and I love this city, that. I think everybody knows that, and I love the people in it, couldn't move fast enough. I understand bureaucracy. I understand folks worrying about liability insurance and workman's comp and all these other things that I heard that was stagnating the progress. But I think what it shows for us is that one person and then a group of people can make things happen. And so when you ask, is it enough? Someone at those other 47 testing sites was getting paid a nice salary while we were working, doing 9 times as many tests at the other testing sites. And again, the reason why is because of access. I told you all those reasons why people got turned away when they showed up. And somehow I became the doctor for the city, for the Black community, and they were all calling me friends of friends of friends from churches and all of this. And I was like, wait a minute, I can't take care of everybody. And that's how this consortium, and I started calling on city officials to say, how can I help? Because I couldn't do it alone. And once it wasn't, I basically reached in my phone and got folks together. And so is it enough? It's a good start. No, it is not. It's a good start for the rate in which we were doing, which again, these are not my numbers. It's all on philadelphia.gov. You can do the math and see what we've done in 26 days of testing.
That's amazing. That's amazing. This question is for both of you, but we'll start with you, Dr. Klasko. I'm curious as to whether or not, maybe this isn't a productive question. I'm just curious. Can you specify what the sort of number one example is of racial disparity in our current healthcare system? Like, what's the number one thing? Like, if we can only just focus on one thing first to try to close and eliminate some of these racial disparities, what's number one on your list?
Well, I think if I was going to do it on a broad number one, I would say social determinants, that we need to spend just gobs more money on food, education, housing, the things that really matter, and that healthcare start at home. Look, I think one of my professors at Wharton when I was there was an individual named Bill Kissick. He wrote a book called Medicine's Dilemmas, Infinite Needs, Finite Resources. Sound right? And he talks about the iron triangle of access, quality, and cost. Just as Dr. Stanford said, it's about access. He said, if you're ever going to try to increase access, increase quality, and decrease cost, then that's going to disrupt the system, and disruption is painful. If anybody ever tells you that they're going to increase access, increase quality, decrease cost, it's not going to be painful for somebody. That can't happen. And to me, that's been my criticism, is that we talk about that all the time. The Affordable Care Act is going to increase access, increase quality, and decrease cost. No, and it's not going to be painful. No, it didn't do that, because it didn't do some of the hard things that need to happen around putting dollars into food, education, and housing. Oh, and by the way, insurers, if you have owned an insurance stock, a middleman stock, they quintupled since the Affordable Care Act.
Wow.
So the last 4 years has been, we're going to have a healthcare system that's fantastic, terrific, unbelievable, and huge. It's not, because we're not making those decisions. So I think what we can do, a lot of this has to be about action. One of the things that Jefferson did, and we have a long way to go. We're not perfect. Incredibly proud of the place, but we did a couple of interesting things. Our last two galas, everybody has galas. People give money. They're generally, and if you look at it for hospitals, to get a bigger MRI than their competitor. We made the decision that our last two galas are going to be for the Philadelphia Collaboration for Health Equity. How can we work with the African American community? That's what led to our relationship with Aaron Walton and Cheney. That's what led to a relationship with Esperanza and the Latinx community. Accelerate our relationship with Project Home. But the fact is, the money that went to that did not go for Jefferson to do something in the hospital. It was for Jefferson to outreach. So if we could all commit to that for the next few years, any gala we have is going to go to the community, not for something for our hospital. That would be a great thing. And then the second thing, and I think in some respects this is more important, there's a great Upton Sinclair quote. It's hard to get somebody to do something when their salary depends upon them not doing it. I got people angry because one article I wrote said, stop looking at a health system's website or what their board says, whatever. Look at how the CEO gets paid. And in most cases, the health system's website will talk about diversity, inclusion, community engagement, disparities, and you look at how the CEO totally gets paid, and it's EBITDA, census, how are we on U.S. News and World Report, and do the doctors that in my system So what we did is, at least as a start, and it needs to do more, it is that 25% of my incentive is based on reducing 4 or 5 different health disparities within the system. Wow. Which, by the way, do I have any control over? So the challenge I would make to some of my colleagues would be that some of the great work that we did do, we talk every week with every major health system here in the city to try to cooperate in the pandemic. If we could take that same, at least, feeling of we're in this together and have those weekly calls to reduce health disparities, that wouldn't solve the whole problem, but it would be a start.
Dr. Stanford, same question to you. If there was just one thing, the number one thing when we talk about racial disparities, pandemic or not, what would you target and try to eliminate?
There's so many, so I'm gonna go with healthcare primarily, and I'm gonna focus on Philadelphia. Having been here long enough to have seen some things, and I would say one, for every kid in this city, they should have access to the #1 hospital in the nation. And that is not the case based on your insurance. It is not the case. And you couple that with a child that goes to one hospital where it's dirty outside, the people are tired, you're waiting, there's a long wait room. And even before that, the prenatal care that the mother may have received or not received, again, because someone's biased about how many babies she's had, if she's a single parent, if she has a job, that trickles to that mother, and then it trickles to the baby. And then that child gets older and they come to the doctor and it's not nice, it's not clean, right? But then at another hospital, it's very clean and it's very nice. And people aren't tired and people come in and check on you. And as a young child, that lets you know that someone is more valued than you are valued. So again, it's access, it's empathy, and it's action. So access right here in Philadelphia would be that all children have access, regardless of what their insurer is, to have access to that hospital. That would be number one. Specifically relating to the pandemic, and I put this call out yesterday in a press conference and said, every academic institution, urgent care, federally funded center, city health clinic needs to let anyone come in and get tested for coronavirus. We're not where we were in April. There are enough testing kits. I should not have professionals from hospitals coming to me to get tested because they can't get tested at work because of the criteria. And so I would implore, particularly with the demonstrations we've had over the past 10 days, where the risk may have been higher for folks who were out there, to just open your doors. Open your doors. Just say from 12 to 6, it's free. You don't need a script. You don't have to have insurance. There's no age limitation. Just come. HRSA is paying for it. So it's not even going to be out of your pocket at this point. So just let people come. And I would say it would be great if you could do it indefinitely, but for 2 weeks, when we know we're potentially expecting a spike, that is access, right? People are already working. They already have to clock in and clock out. They're going to be there. So just let people come in. There was a big sign as I was driving down Broad Street at Broad and Ridge next to a church and an FQHC. And the sign said, free COVID testing. I was excited. I said, wow. And underneath it, it said appointment only. Right? So that's what I'm talking about. Let's do it in real time, right now. And the testing sites I've seen, and again, and this can be extrapolated to everything else, there are no people there. You know, Mayor Kinney and Commissioner Farley came out to our testing site yesterday. We tested almost 300 people yesterday. Okay. And that's our third time at that location. The first time we tested almost 400 people in a day. Wow. Right. And he asked me, how do people keep coming? How do you get the word out? And it's trust and it's empathy. And you go to all these other testing sites in the city and there's nobody there because of the barrier, because of the lack of trust, because there are more police officers there than there are people testing. And for a lot of folks, and you know how people feel about seeing the police, it's not welcoming. It doesn't say, please come, we want. So again, the action item there is for the institutions, test your folks. And if you don't have enough tests, send them to me so I can test them, because it's not okay for a nurse at a hospital to say, I need to be tested, and she's Black, and her white supervisor to say, you're not sick enough. And then she comes to me and she's positive. Her mom, who's elderly, is positive. Wow. She worked all week. She was in the break room with her nursing colleagues and then exposed her husband and her 2 children. Wow. So it's empathy, right? And I think if people didn't have the barriers and these criteria right now to test, that would help a little bit, because you wouldn't have to worry about someone's empathy. It could just be anybody can get tested. So let them get tested.
Right. Right. Amazing. Dr. Klasko, in your forthcoming book on healthcare, you and your co-authors argue that we need a paradigmatic shift in our thinking about health insurance and health. And that transition is to something that you guys coined as health assurance. Can you explain that to our viewers and listeners, please?
Yeah, I think it gets back to how do we start to really make a difference for the social determinants that Dr. Stanford was talking about. It doesn't happen in a hospital. 95% of people don't view themselves as patients. They view themselves as people who want to be able to thrive without health getting in the way. And the way this book starts, because I'm partnering with the head of General Catalyst, which is the largest venture capital firm out in California, to make Philadelphia into the healthiest city. General Catalyst was the initial investor in Airbnb and Warby Parker and Bongo. And the whole concept was, it used to be if you want to build a bigger, better hotel than Marriott, you build bigger, better hotels. With Airbnb, you just brought things that already existed. Taking that same model of health and not having to be all about the hospitals, the costly sick care is going to give away to affordable, personalized, and preemptive care, partly through technology. But here's the issue with technology. And every time we've had an industrial revolution, the Industrial Revolution, we look back and say, gosh, I wish I had changed something. If we knew what we knew about internal combustion engines and what they would do to the environment, we might have changed that. If we knew what we knew about the social media revolution, and that it wasn't just going to be people looking at their grandkids, it was going to affect elections, we might have made some changes. So we're on the verge of what we call the fourth industrial revolution. 5G, robotics, AI. And the question is, let's up front look at how that can not have unintended consequences. We've already seen AI on the police force actually bake in racism. For us, we want to make sure that the technology we bring into healthcare is for everybody. It's not just wealthy people that are counting their steps on Fitbit. So let me give you an example where it can make a difference. We're working on I'm an obstetrician, and we're working on with a company that do almost all monitoring at home or at work as opposed to having to come to the hospital. Now, you might say, well, how does that help? Well, believe it or not, in obstetrics, we spend somewhere around 2 to 5 times as much as any other country in the world in obstetrics. And our maternal morbidity, our neonatal morbidity, as Dr. Stanford knows, is somewhere around number 20 or 21, somewhere around Serbia. So why is that? Well, the reason it is like everything we've talked about. Everything is built for the insurance companies, the providers, and pharma. So, Mrs. Jones, we need you to be tested 3 times a week. Come into my hospital 3 times a week to get tested. So think about this. I'm going to come in, I think about this post-COVID. I'm going to come in, pay $35 to park, go to a place where a lot of sick people are, go up to on the elevator, get in a room, have a monitor placed on me, and 2 hours later I'll be told I'm okay. Now, if you have unlimited means or you have a job where they say, yeah, Mrs. Jones, of course you can leave, that's great. If you don't, and your choice is, look, if you leave 3 times a week, you're going to be out of a job, or I can't afford the nanny, you just don't get those tests. So just like we talked about COVID, there's a much greater risk of neonatal and maternal morbidity among African Americans, people who are underserved, because they don't get the test. So the key for us will be making sure that the new revolution, the new technology, starts at home and is available for everybody. And just we call that healthcare with no address. I hope in 5 years, if you ask somebody where Jefferson is, they can't tell you. You mean Jefferson at my home, or Jefferson over at Project Home, or Jefferson at Esperanza? Oh, you mean the place where really, really sick people go to get transplants? I think that's still a tenth of Walnut. We have to stop being defined by our most expensive hospital and start being defined by how we're caring for the community.
We're going to have to get ready to open this up because we're running a little bit short on time. But I just want to give you both a final question before we take a couple questions from our audience. Can you both give us, and we'll start with you, Dr. Stanford, can you both give us your best case, worst case scenario of the impact of the current nationwide protests on the spread of coronavirus and COVID-19?
Best case scenario is that we are approaching herd immunity, meaning everybody has it now, so you're not going to see it go up. I'd like to believe that. And it might be true because the positivity rates when we started testing were 24 to 40%, which was way above the national average. Now it's 12%, 10%. So it's decreasing, right? So if the protests and the demonstrations had happened, for example, April 14, 15, when we hit the peak in Pennsylvania, this would be a totally different situation and scenario. Because back then, it was 1,000 people per day being diagnosed with coronavirus in the state of Pennsylvania. And in New York, it was like 800 deaths per day when they were at their peak. So if you can imagine, there was that much contagion just in the air, literally, and folks were out there shoulder to shoulder, it would be totally different. It would be a true survival of the fittest. I mean, it already is, but in real time, we would have seen that. So I think the best case scenario is that a lot of people have had it, so it may not be as high. And that too, we have more testing sites, we have more resources and more availability. And even the CDC is saying, if you were out, get tested within 3 to 7 days of being exposed to a crowd. And we had a lot of folks come out yesterday to get tested because they were out protesting. That's best case scenario. Worst case scenario is we're not going to see it till 14 days from now. That this downward trend that allowed us to go to yellow is going to go up and go up and go up until it plateaus. And if the hospitals that hadn't caught up yet from the initial surge get those patients, we're going to be back in a not great cycle, right? And so time will tell with that. And if that does happen, those who were predisposed are just going to be at greater risk, and some are going to make it and some are not.
Wow. Dr. Klasko, do you want to add anything to that?
Yeah, so I think look, the best case scenario is that I love hearing people say, it's a public health crisis that people are protesting. What it's really done is made it clear that health disparities are also a public health crisis. I worry more than anything about what I call the pandemic. That people, after the pandemic, that people aren't going to get the care that they need around heart disease and diabetes and other things, of which, again, the African American community is even more susceptible to. I think, but having said that, there's a reality to the fact that we can't pretend to get thousands of people together isn't a risk. I mean, if we did, we don't think it's a risk of COVID, then we should open up everything. I mean, one of the things that has really frustrated me is the lack of consistency in what we've said, both across states, across counties, et cetera. So, yeah, it's definitely going to be a risk. I agree with Dr. Stanford. It would have been a bigger risk if it happened a month ago. But, it's sort of laughable for people to say, no, it's not a risk for the protesters. It is a risk if 10 people get together, in a restaurant. They're both risks, and we're at the point now where everybody, given the statistics that Dr. Stanford said, has to make some of their own decisions about what risks they're willing to take. Obviously, thousands of people are making a decision that they're willing to take that risk for a cause that they firmly believe in. And I think that's a good thing. But we can't pretend that that's not a risk of increasing and creating a mini surge for COVID.
A really quick station identification check because we're running over to the 7 o'clock hour. This is the Philadelphia Citizen Virtual Town Hall on healthcare disparity in the era of COVID-19. I'm moderating. My name is James Peterson. I have two extraordinary panelists, Dr. R.E.A.L Stanford, who's a pediatric surgeon. She's the pediatric surgeon who founded the Black Doctors Covid-19 Consortium, and Dr. Stephen Klasko, who is president and CEO of Jefferson Health. So we have a lot of extraordinary questions that we won't be able to get to all of them, but I want to give you a few of them so you can respond to them, and hopefully we can go through these quickly so we can get 2 or 3 of them in before we have to wrap the show up. First, Leela asks, are volunteers needed for the testing efforts? I'm assuming that's to you, Dr. Stanford. Do you still need volunteers?
We always need volunteers. Right now we have a lot. But you can go to www, it's very easy, Black Doctors Covid-19 Consortium, and put in your contact information if you're interested. Sure.
Awesome. And from Sandra, she asks, how accurate is the COVID testing?
Did you?
Either one.
I'll start. I mean, I think some of it is changing on a daily basis. The nasopharyngeal testing is fairly accurate depending on the stage, but that is a very, very high intensity test. Frankly, very uncomfortable. Requires PPE. What we're looking forward to is a saliva test that is being tested where people can actually do that at home. Mm-hmm. And again, the reliability of that, the sensitivity and specificity is still being tested. Similarly, the antibody tests, which are the whole other thing, do you have antibodies, are also inconsistent. Because we've had some folks that have positive antibodies on one test, negative antibodies on another. So testing is more plentiful. It's good. Certainly the intensive nasopharyngeal test is the most accurate right now. But I think things are moving quickly enough that we'll start to see some changes.
Sure. Dr. Stanford, someone asked, where is your testing site?
So we move all over. Our next site, we're actually going to be in Chester County, Yeadon, and forgive me, it might be Delaware County. I'm not super big on the outside of Philadelphia.
I think it's Delaware County.
It is Delaware County. Okay, so we're going to be in Yeadon at a church. I want to say, I'll get it to you in 1 second because I'm not sure the exact name, but we'll be there. We're actually testing. Okay, so we'll be at the Chapel of Good Shepherd Church on Saturday, and we're actually going to be at Fern Rock tomorrow testing SEPTA workers because, as you know, they had several people die from coronavirus early on, and
yes, that hit home very close for us here at the station.
Because they were out there, really keeping the city going so folks could get to work and public transportation and so forth. So that's where we'll be tomorrow.
Thank you. Dr. Klasko, I think this one is for you. Anne asks, has the impact of stress, specifically stress of being Black in America, been studied in relation to racial health disparities?
Well, what a great question. So the answer is a lot of work on the impact of stress and heart disease, a lot of work on the impact of stress and neurologic disease, and actually some interesting work on the impact of stress and autoimmunity and immune responses to cancer. So the first answer is stress is bad. I think you could probably answer better than I could whether or not, and it's a rhetorical answer, but I think an African American who's lost their job, one member of the family's lost their job because they're a restaurant worker. The other member of the family is an essential health worker going to work every day with COVID patients. I believe that couple is a lot more stressful than Kim Kardashian and her husband in the Hamptons. And I think so. So yeah, clearly your current situation makes you more stressful. One of the things we did at Jefferson is we created a Better Together Fund, almost $8 billion for the most vulnerable of our part of our family, our employees, our environmental service workers that are coming to work, putting their family at risk, and then going home. And it's been great to see some of the stories out of that. But those are the real heroes. The real heroes are the people that said, this is a war, right? And this is the only war where you go home to your family and take the war home with you. And I think we need to really recognize the heroes that are out there. Yes, it's the doctors. Yes, it's the nurses. But it's the essential health workers. It's the environmental service workers in our hospitals. It's people like Dr. Stanford who didn't have to do it but took on the challenge. Those are the real heroes.
That's awesome. Listen, I want to thank both of you so much for your time. A couple of things we got to do some house cleaning before I properly thank you. First of all, the Philadelphia Citizen is going to host State Treasurer Joe Torsella next week. And for all of my WRD folks, tonight on WURD is coming up in a few minutes. So for folks who are watching on Philadelphia Citizen, if you want to listen to my radio program, please tune into WRD at 96.1 FM, 900 AM, or WRDradio.com and the free WURD app and all that great stuff. But I am just so grateful and thankful to you, Dr. Stanford, and to you, Dr. Klasko, one, for all the extraordinary work that you guys do in our community. You literally save lives. So thank you for the work that you do. And we all really just appreciate the time you took out of your extraordinarily busy schedules to shed some insight into us around health disparities and the things that we're doing in the city of Philadelphia to directly address them.
Thank you.
And thank you for all the honest information you're giving people. And thank you for giving me a chance to give a shout out to the late, great guy.
Georgie Woods, no doubt. Dr. Stanford and Dr. Klasko, thank you guys so much.